Hi, my name is John Gibbons and I run a company called the John Gibbons Body Master Method, and I am an osteopath, a lecturer and an author. And today's an interesting concept because it covers a few areas. I'm going to talk about the proximal Tib-Fib joint. I'm going to talk about the tibia being anterior in respect to the talus, and then I'm going to talk about the talocrural joint of the ankle. And so we're going to cover basically three areas, I guess. This was shown to me many years ago, and I quite like the concept. I haven't quite got my head around exactly how it works, but it seems to work very well for me. And the first thing that I was shown is that you get the patient and you ask them to turn the foot out. So turn the foot out. So you're everting, and then let's say you can overcome them and there's a natural weakness. Obviously, the weakness could be coming from the S1 nerve root, and the S1 supplies the peroneals. Also, the S1 supplies the plantar flexors, and the S1 supplies the and also the gluteus maximus. But in this case, it might well be that the patient has gone over on their ankle. The patient might have some issues with the bicep femoris. When I said gone over her ankle, maybe not in the last week or two, maybe in the last 4 or 5 months, but now she's complaining of, say, knee pain. And it is important that any knee pain, we look at obviously the hip, but in this case, we're going to look at the ankle and the foot. And the test would be for the weakness of the everters because of the peroneals. And if we were to assess the proximal Tib-Fib joint, now this is a synovial joint proximally, synovial gliding, but distally, even though it's the same bone, so you've got the proximal Tib-Fib here, which is a synovial joint, and you've got the distal Tib-Fib joint here, which is a syndesmosis, which is a type of fibrous joint. So they're almost like the same proximal distal, but they're actually a different classification. And what sometimes happens is that you've gone over on your ankle, and when you dorsiflexes, you can't really show it in this one, but when the patient dorsiflexes, because of the shape of the talus and then the fibula, it travels further, it almost has to open up to allow the talus to glide, which then means because it opens, there's a motion here, but then there's a motion proximally. And sometimes it gets a bit stuck. Because it gets a bit stuck, the bicep femoris now has a problem, so you might get a tendinopathy here. And it's very easy to treat with tendon, but it's not the problem. The problem is this joint might be fixated, but it's not that problem either. The problem is coming from the foot. But we might start here, and I'm going to start here, and then I'll come down. So the first thing we'd look at is the assessment. So we bend the knee at 90, and the idea would be that we're able to hook behind the proximal fibula. And when we look at the gliding, it's not so much to the same shoulder. The gliding is almost like to the opposite shoulder. So we come on the thumb and finger. We have to be careful because slightly inferior will be the peroneal nerve coming from the sciatic nerve. So we almost have to glide it. And yes, it does move a little bit, but if it doesn't move very well, coming this way, but maybe it's stuck this way. Okay, so maybe it's stuck, we can say anterior if you want to. In fact, in this case, it will be posterior. So I'm going to try to glide it anteriorly. Even though you can see movement here, I'm just going to do a little technique. I'm going to use my proximal joint of my finger, my index finger, so the MCP joint. So I'm going to come behind, and then I'm literally just going to bend. So my pressure is behind, almost like a wedge behind. And then I'm going to come in. I tend to turn the tibia slightly externally. I come in with pressure, and then I can do a little thrust, like so, 2 or 3 times. Sometimes you'll feel an obvious click where it does cavitate, and then we can reassess, but it doesn't always have to click. Even just by mobilizing will help. The second thing we're going to do is I'm going to look at the tibia in relation to the talus, and then I'm going to apply pressure onto the tibia here. I'm going to dorsiflex, turn the leg in slightly, a few degrees, 5 degrees, and then I'm going to feel the fibula distal, and I'm just going to mobilize it going posteriorly. And again, this is a nice little technique to mobilize the tibia posteriorly in respect to the talus. Sometimes I'll lock it and I will thrust, and again you can hear an audible click where it's truly fixated. But you can see I can spring, and I'm just literally just going to spring it downwards, and then that moves quite well. And the last thing I'm going to do is come onto the top of the talus, and the way I do this, middle finger we cross like this, okay, so we almost like interlock and we cross over, and then the talus is here, and the way I do this one is There's the talus bone. My finger, middle finger in particular, will come on top, and I will dorsiflex, and I will evert to lock it down. I apply a little bit of traction, like this, and then from here, the technique is, if that's the talus bone here, it's almost going to be inferiorly, posteriorly. So from here, I am going to pull, traction, and then the thrust is going to be more like this, okay? And again, there's the lock, and then there will be the thrust. And again, some patients could cavitate on that particular motion. Once we've done those 3 techniques, is what I do. So I do prox, Tib-Fib, I do the tibia on the talus, and then I do the talocrural joint, as in the talus in particular. I will then retest, turn the foot out, hold, 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 okay? And then hopefully they will be a lot stronger. And then you might find over the next week or 2, the pain to the bicep femoris will start to ease off. And there you have a variation, if you like, of treatment to the lower limb, even though the patient perceives pain to the insertion on the bicep femoris. Thank you for watching. If you can subscribe, then you